Imagine you wake up in the morning and you can't move your arm. You can't feel what's going on down in your hands. So what are you going to do about it? Stay with us for this next segment of Kentucky Health when we talk about how to diagnose neurological disorders.
Kentucky Health addresses the healthcare concerns of all residents of Kentucky and surrounding states. It was created by Dr. Wayne Tuckson, a colorectal surgeon practicing in Louisville. Here is your host, Dr. Wayne Tuckson.
Hi, and welcome to this segment of Kentucky Health. Today we want to talk about neurological disorders, particularly things that go wrong when the nerves just aren't functioning the way they should function. Now, if you will, imagine that the body has an electrical system, which is essentially these neurons, nerve cells, and nerve fibers that go throughout all of our body that tell us to do the things. We think about something and we close our hand or we move our arm. Now, imagine that you're sitting there thinking, I want my arm to move, and you're looking at it and the arm doesn't move. Or just imagine, I know I have an arm down there, I can see it, but I can't feel it. Just imagine how scary, or if it's your leg or your hip or just anything in your body that just isn't working the way it should. How do you go about trying to find out what's wrong, and what do you do to try to correct this problem? And we're fortunate today to have with us somebody that's going to guide us through this maze of the diagnosis of a patient with a neurological defect, Dr. Jeffrey Frank, who's with the Norton Neurology Service. Jeff, thanks for being with us today.
You're very welcome.
Now, I got to tell you, I remember as a medical student, we were always amazed by the diagnostic ability of the neurologist. It seems like you guys can make a diagnosis and say the problem is in this nerve or in this portion of the brain. That's amazing.
It doesn't take much to do that. It's just a matter of organizing it to decide where the lesion is. When you have a problem like you described, you can't move your arm, you have to decide, is this coming from the brain? Is it coming from the spinal cord? Is it coming from the nerve roots? Is it coming from what we call the brachial plexus? Or is it coming from one of the nerves? And you break it down like that, and you ask questions and examine to decide where the problem is. And once you do that, it's easy.
So you can eliminate muscle things, you can eliminate bones, and then it's just saying, okay, where does this nerve thing go?
Correct.
Now, what is the layout of the nerves in our body? How does it work?
What happens is that all the neurons start in the brain. You have areas, the motor areas in the brain on either side, and the neurons project their axons downward, and it goes down through the brainstem into the spinal cord. And at the cervical spinal cord, you have nerve roots that come out and go into the arms. The spinal cord goes down, and you've got nerve roots that come out into the legs. So it's organized so that you've got, now I have to organize my thoughts. It's organized so that at certain parts in the brain, if you look at it, you've got the legs in one part and the arms in another part. So say you have a stroke in one part of the brain. If it affects one part, you can affect the arm. If you affect the other part, you affect the legs. At the level of the spinal cord, you've got discs that can rupture and press on the nerve roots. You've got, as the nerves come down into the arm, you've got a very complex organization of the nerves called the brachial plexus, which we'll take a little look at later. And all kinds of things can happen there. Athletes can injure it, or when you have surgery, depending on how you position it, you can injure the nerves. Then you've got the individual nerves in the arm, and there are various things that can injure them. The most common is carpal tunnel syndrome, where at the wrist, just from everyday wear and tear, you can damage this nerve. That's one of the most common. you can damage the ulnar nerve at the elbow. You can damage the peroneal nerve at the knee. So at different places, you can damage the nerves different ways.
If you damage a nerve, does it ever come back to being normal again?
It depends on how much you damage the nerve. There are different degrees of damage. The first degree of damage is just damaging the coating around the nerve. If you do that, then usually you can have recovery within a couple of weeks. If the damage is deeper and it damages the axons, then what happens is you actually get dying back, and it'll stop. Then it takes time for the nerves to regenerate. And nerves regenerate very slowly at a rate of 1 inch a month.
Wow.
So say you damage your nerve here. Well, what happens is it's not just right here that the damage goes up this way, but then it may take several months to grow back. If you sever the nerve completely, there's a good chance it won't recover at all. So those are the different levels of damage that you can do to the nerve.
Is there a difference between a nerve motor that tells you a movement nerve and something for sensation, or is it all the same nerves?
No, there are two types of nerves that we look at. There's the sensory nerves and the motor nerves. They come out, if you look at the spinal cord, if you were to take the spinal cord and cut it and then look at it, the motor nerves all come out from the top. The sensory nerves come out from the bottom. And so they're separate to begin with. Now, some of the nerves that we have both motor and sensory components. There are some nerves that are pure motor and some nerves that are pure sensory. And it all depends on how much damage you do as to what symptoms you get.
Now, you mentioned that things come from the brain down into the spinal cord. Is this all are these just one long nerve fibers, or do they communicate with one another?
Well, there is communication at different levels. As the nerves come down from the brain, they synapse on a neuron in the spinal cord, which then sends an axon down into the arm.
Now, when you say synapse, what do you mean?
Synapse means connect.
I see. Okay.
So it connects on this neuron, and as the impulse comes down, it activates it, and it activates into the arm to activate a muscle. So then you've got feedback, because then you've got nerves that come back and feed back onto that. So it gets to be very complex. It's very simple when you say there's just one nerve, but the communication is endless.
Well, since you bring back that feedback loop, what's a reflex then?
Well, reflex is part of that feedback loop. When you hit a muscle tendon, it sends a signal back, which in turn activates the muscle.
Is that what you're doing with the dreaded hammer?
That's what we do with the hammer.
Okay.
Is we're testing the muscle tendon reflexes. Those are all just feedback loops.
Now, occasionally I've seen, and remember using as a resident, and can't say I use it nowadays, the little tuning fork. What are you looking for with that?
That's looking at vibration. There are different types of sensation you look at. You can look at vibration, you can look at position sense, you can look at pain and temperature, and those are all carried by different types of nerve fibers. You've got the very big myelinated nerve fibers. Now, myelinated means it's coated with that coating I talked about.
Okay.
The pain and temperature is the small unmyelinated nerve fibers. So there's actually different types of nerves that carry different sensations.
I know that when a person has a stroke, that's because poor blood flow to the brain. Can you get a similar thing in the extremities where decreased blood flow affects the nerve?
Yes. Typically with diabetes, you can get an ischemic lesion of the nerve. A lesion means a damage to the nerve.
Okay.
With diabetes, you get problems with the very small blood vessels that control the nerves, and they close up. So essentially, you get a stroke involving the nerve. There are other things that do that, but diabetes is the most common.
And that's why some patients with diabetes will lose sensation in their fingers or toes, or?
It's one reason. They also have what's called a peripheral neuropathy. Now, we've been talking about damage to single nerves, but when you have damage to all the nerves, that's called a peripheral neuropathy. That's where the nerves die. And diabetics get many different things, but they get a peripheral neuropathy and where all the nerves are dying, starting at the very bottom and working up. But they also get these mononeuropathies, which is a single nerve damage, which can be from what we just talked about.
Okay. Now, I want to get to this thing. I mentioned about the little hammer thing that you go around beating people with. You said you're looking at a reflex. I think y'all just mean people.
We can be.
Okay. So now, when you're talking about looking at a nerve, I guess it's important to know how the nerve goes, the course of that nerve then.
Yes.
So you have to look at that.
Well, it's not only the course of the nerve, you have to know what muscles each nerve innervates. This is why most medical students don't like going into neurology, because it's complex. And even a lot of neurologists aren't familiar off the top of their head with which nerves control which muscles, which nerve roots control which muscles. And that just takes, for me, because I'm an electromyographer, which means, I guess we're going to talk about the EMG in a second, but because I do that test, all of that stays fresh in my mind. But it is very important to know how that's laid out. You have to know which nerve innervates which muscles, because when you examine somebody, the weakness that you find, the distribution of the weakness, can tell you where the problem is. It can tell you if it's a local nerve or it's higher up.
What is, you brought it in, so let's talk about it.
Okay.
EMG, what is that?
EMG is actually two tests rolled into one. We call it a nerve and muscle test. It looks for problems involving the nerves and muscles. So there's two parts. First is the nerve conduction study, and second is the EMG, or the needle examination.
So the needle is not actually looking for the nerve, you're actually looking at the muscle.
The needle looks at the muscle, but we can tell if there's a problem with the nerve by the electrical changes in the muscle.
On this first slide that you brought with you today, now I guess we're looking at an arm here.
This is the arm.
So what are we seeing?
Well, what we're seeing is that we would actually hook up patients a little bit, one at a time, but this is showing how we would hook up a patient for a nerve conduction in the arm. We would hook up electrodes on the hand, either at the thumb to look at the median nerve, or the hypothenar eminence to look at the ulnar nerve, and that's what the dots are on the hand, and then you stimulate the nerve at two places, down at the wrist and up at the elbow. And what you're looking at is you look at the response that you get. You're looking eventually at how the nerve transmits that impulse of electricity. But you want to look at how big the response is, how long it takes to get from here to here, and then you also look at how long it takes to get from here to here.
So you're measuring the actual time from the point of stimulation till it gets down to a certain
The response,
point?
it's time over distance, which is velocity. So that's why it's called a nerve conduction velocity.
I see.
And each nerve has its own normal value on how fast it's supposed to transmit it. So what we do is we compare what we do find in the patients to the normal values as to whether it's conducting it normally.
And so you then take that and say, okay, can you say then what caused the problem, or
No.
You just say there is a problem?
Well, you can say there's a problem. There are very specific changes you can see on nerve conductions that can tell you if it's an axonal damage, like we talked about, whether the nerve is damaged or whether the coating is damaged. There are certain findings that you can tell. This is getting very microscopic with it, but you can tell that.
So what happens if you have a delay in transmission? Is that bad, or does the transmission increase if there's damage?
Okay, you have a delay in transmission if it's bad. The slower the nerve, the worse it is.
I see.
Normal nerves in the arm transmit at 49 meters per second.
Wow.
Okay, if it's 39 meters per second, that's very slow.
Okay. Well, on the second slide you brought with you, now
Okay.
we're looking at what? A leg, I guess.
We're
in
looking at
this
the
case.
leg. You can do the same thing on the legs. This particular one's the perineal, and you hook up the electrodes on the foot, and you stimulate at the ankle and at the knee. And it's the same thing. You look at the response, You look at how fast the impulse gets from the knee to the ankle, and that's a conduction velocity. You can tell how big the response is and how long it takes to get from the ankle to the muscle itself.
How are you stimulating this thing?
We have some electrodes. What you can see on here is that it's a box with two little prongs on it. One's positive and one's negative. And we put that on the nerve and we give us a shock of electricity. And the way we've got is it will travel towards the nerve.
Okay. So then that's how you, is this uncomfortable for the patient?
It's uncomfortable, it's not very painful. It feels funny. People who use spark plugs, you know, it's like a shock of a spark plug, like an electric fence a little bit, like a barking collar for a dog. It gives a little shock. So it's a little scary sometimes, it's a little bit uncomfortable. I tell the patient it's not particularly painful.
As long as you're the one doing it.
It doesn't hurt me a bit.
There you go. Now, if you would, let's go through this next montage, if you will,
Okay.
And tell me what you're doing while you're doing this examination. So if you could just kind of take us through this thing.
Okay. The next part is what we call the EMG, or the needle examination. And what this is putting a needle electrode in specific muscles. Okay, first of all, what I'm doing here is looking for the muscle itself. But once we find the muscle, as I said, I'm asking him to do a certain task, and then I'm feeling where the muscle is.
I see.
And then what you'll see next is actually I'm holding the needle. And it's a relatively small needle. Okay, I put an electrode on the muscle. This is a muscle on the outside.
So once you've identified where that muscle is, you just put that electrode right there.
I put the electrode this is the reference electrode. And then I'm going to actually get the needle, which is right there.
This looks like a very narrow or very small needle.
It's very small. It's a 26 gauge needle. It's about 1.5 inches. And then I put that directly into the muscle.
Okay.
Okay. It's a little bit painful. I tell patients, I'm going to stick a needle in you. It's going to hurt, but it's not unbearable.
Okay.
So then I look at resting activity in the muscle. Usually at rest, a muscle doesn't have any activity at all.
So that's what we're seeing on the
Well,
screen
what we're seeing is actually he's activating it right there.
Okay.
These are motor unit potentials. But at rest, the muscle doesn't have any activity at all. If there is activity, then it's abnormal.
Okay,
And
I
typically, when you damage a nerve, then you see what's called spontaneous activity.
I see.
Then I have the patient activate the muscle, and I look at the motor unit potentials. You look at how big they are, and you look at how it fires. If in a normal muscle, as you're putting more pressure on it, you will get an increased rate of firing, and you'll pull in more motor units. And that's how you increase the strength.
Now let's go back over something there.
Okay?
A motor unit, what is that?
The motor unit is what we see on the screen. That's the electrical representation of a muscle firing. We call that a motor unit. So when one muscle unit fires, the needle picks that up and it transmits it to the screen, and that's a motor unit.
Is that because one nerve cell is telling one muscle fiber to fire off?
Yes.
Okay.
So, and again, as you give more and more effort, you're going to pull in more and more of these motor units. So now there's two ways that you can make it stronger. You can either increase the rate of firing, or you can pull in bigger motor units. So if you've got damage, the first thing that you see is the motor units are big. They're all big. The second thing you're going to find is that the firing is very fast, because they're trying to get stronger, but there's not other motor units coming in. So you get a very hollow sound. So this is another indication of nerve damage. Okay, so what happens is we find nerve damage in a certain muscle, and then what we do is we look around at similar muscles to determine what's the distribution of the damage. And by that distribution, we can tell where the nerve damage is. For example, in the leg, say you wake up with a foot drop. There's several things that can cause a foot drop. One is damage to the peroneal nerve at the knee. So if I look at at muscle groups, if I look at the tibialis anterior and peroneus longus muscles, and they're abnormal, and nothing else is abnormal, that means the problem's in the peroneal nerve. But if I do that same test and the tibialis anterior, the peroneus longus, and the posterior tibialis muscle are abnormal, that tells me that it's coming from the back. It's an L5 radiculopathy.
So because you have a broader distribution of the damage, it's got to be further upstream.
Correct.
Okay.
As I said, the distribution of the damage tells you where the problem is. So that you have to have a knowledge of what innervates what to be able to interpret that.
Let's take a look at this picture of the brachial plexus, because this is always a very complex area where a lot of stuff can happen.
Right. Well, this is an example of what you see in the arm. At the shoulder and the neck, what happens is the very first thing you see is the nerve roots. The nerve roots come out one by one. And in the arm, it's the C5 through C7 nerve roots, or through T1 nerve roots. They all come out, and what happens is they join together in different conglomerations. And this is the brachial plexus. So this is what happens in the shoulder. And then from the brachial plexus, you have individual nerves coming off. You've got the median nerve, you've got the radial nerve, which comes the back, and the ulnar nerve, or the three major nerves. So again, you can have damage at any place along the nerve, and my job is to find out where that problem is.
Wow. So it can be as far up there
It can
and
be at the
cause your
nerve root,
problem way down toward the hand.
Right. Or it can be way down in the hand causing it and you don't see anything else.
You identify where the problem may be. What do we do about it then?
It all depends. It depends on, then it's determined what caused the problem. If it's damage to the nerve by trauma, then the only thing that usually you can do is time. Say it's carpal tunnel syndrome. That's usually trauma over time, is as you use your hand, you are repeatedly traumatizing this nerve. Okay? So we can do one of several things. First of all, you can keep the nerve, let it heal up, like at night. You put a wrist splint on, so you can't squeeze it.
Gotcha.
So that lets the nerve heal up some. If that doesn't work, then you have to actually go in and decompress the nerve, open it up and so that you're not having as much pressure on the nerve. The problem with that is that if you go back and doing exactly what you were doing before, you damage it again. If something is pressing on the nerve, say you've got a ruptured disc in the neck and it's pressing on a nerve, then sometimes that requires surgery to take the pressure off. Or you can do different maneuvers like physical therapy and try to get the disc off the nerve so that it can heal up. Most traumas to nerves, you can't do anything at all. It's a matter of time.
Just waiting it out.
Just waiting it out.
Steroids or other medications, any value?
Yes and no. Sometimes if you have an inflammatory process, there are episodes of inflammation that can affect things like the facial nerve, which is called Bell's palsy, or you get an inflammation in the brachial plexus, which is called Parsonage-Turner syndrome. We do use steroids for that. That's an inflammation, and that's what steroids are good for. Sometimes if you compress a nerve, you get inflammation also, and you can use steroids. But the steroids aren't going to heal the nerve. It may reduce the inflammation and then let the nerve heal up on its own. But as you remember what I said initially, if you damage the nerve, it can regenerate at a rate of 1 inch a month. So if you damage it way up here, sometimes it won't even get all the way down here. Or it may take years to get better. So.
Boy, it sounds like almost kind of be very frustrating, I guess, for both the physician and for the patient.
Absolutely.
Well, it sure sounds like, though, there are things that can happen to us. And a lot of times when we, I guess, have a little tingling in the hands or the arm or feel a little weakness, many of us try to ignore it. And I guess if we ignore it, that causes repeat injury, repeat trauma. which may cause some permanent damage. It sounds like the best thing to do would be to go and seek out an opinion to try to identify where is the problem, so if they can identify what the problem is, seek some type of therapy. And it doesn't, sometimes it may require surgery. Sounds like sometimes just doing some physical therapy, perhaps sometimes maybe something medical even take care of it. Dr. Franks, I want to thank you very much for being with us today. I think it's been very interesting.
Pleasure.
It's nice to talk to somebody that knows how to find a road map and develop that map and guide us to where we need to go to take care of patients. If you have questions, feel free to contact Dr. Frank or any one of his associates at the Norton Neurology Service, or feel free to contact us at Kentucky Health at insightbb.com. I'd like to thank you very much for being with us for this segment of Kentucky Health. Dr. Frank, again, very interesting. I want to thank you again.
You're very welcome.
Please feel free to join us again for the next segment of Kentucky Health.